I was thinking about this case. I don't think I did my best on, or rather, the outcome wasn't as I would have hoped. And I just want to process it, right? So there's this guy who came in. He's an older guy, but pretty healthy. Doesn't see the doctor regularly. And, he had a pneumonia. It was obvious on imaging. He had a real pneumonia. Wasn't too bad. It wasn't on oxygen. Didn't look horrible. His labs aren't great. Having fevers, but hey, having pneumonia, we'll treat it. So in the case of pneumonia, usually we don't get any organisms because nobody's going to stick a needle into the lung to get an organism. You can have people cough things up, but oftentimes people can't cough things up. If they can, you have to still send it to the lab, and then they do a validation score to see whether they think it's from your throat or actually from your lungs. If it's from your throat, they don't bother testing it further, and most people it's from their throat. And then finally, if they test for it, you may or may not get organisms growing out. So I don't usually send off it because it's just a waste. And getting people to cough it up by having them inhale salt water just sounds sort of nasty and not really necessary when most people get better. They always do blood cultures, but those don't pop up much at all. And a lot of people do these other antigens that take a while to come back and aren't that helpful. Anyways, somebody ordered a swab, which is a PCR, just genetic material testing, much easier. And I already told him that first. That, yeah, why do we give two different antibiotics? We're trying to double cover for things, right? And just the ones that cover the atypical organisms, they're not so great necessarily at covering the standard strep, pneumoniae. But other atypical ones, I don't even know if we need to cover really, because they're like walking pneumonia, mycoplasma. People don't get too sick. And he comes back mycoplasma, which I thought was strange. He's not that old. Why is he so ill? He should be able to walk it off because it's walking pneumonia. Doesn't have HIV or anything significant like that. He's healthy, functional, normal person you see on the street. So that should have been the first red flag, and it was. And I ran it by the lung doctor, who wasn't impressed. I checked a number called a procalcitonin, but in my hospital here, it takes a while to come back. That number was sky high. Like positives like 0.5, 1. His is like 30, 40. Way, way high. Something's weird here. Something's not fitting. So I looked it up. There's something called fulminant mycoplasma. There's only case reports. It's not well understood. But some people get really bad mycoplasma disease. I think it has to do with the immune system. So they treat it with steroids because they're trying to make the immune system not react. Anyways, next few days, it sort of gets worse, little bit by little bit. Starts having other issues, little bit by little bit. Atrial fibrillation, blah blah blah, which happens to people. He's older, and then finally, he worsens, requiring a lot of oxygen. He's put on high flow. That's not great. I've been talking to the lung doctor every day. Lung doctor finally sees him. Steroids are started. He's better. So I knew you treat fulminant mycoplasma with steroids, but I didn't want to order it because I didn't have the diagnosis. I don't know how to diagnose fulminant mycoplasma. I've never seen it before. His procalcitonin level is getting better. Shouldn't that mean he's getting better? Well, he's not. What does that mean? Is it fluid he's building up? That could be. I think all that is sort of secondary. I think it was fulminant mycoplasma looking back. I wished I started him on steroids sooner, but I didn't. And that's where I'm conflicted. I still believe, and I still do, the vast majority of the time, on treating things because I know what things I'm treating. Some people just throw stuff willy-nilly. I can see a lot of people using steroids. They make people feel better. But should we be using them in so many random cases? I'm not clear because they have risks. Is getting my patient out of the hospital good enough? Again, is this good for them long term? They would have gone to the hospital anyways, might have taken longer. But I don't think they would have been harmed without steroids in most cases. So I do stuff because I know what I'm doing. I know why I'm doing it. Blood pressure medications. You got to choose the ones that actually have mortality benefit. The ones that reduce your risk of stroke. You don't just choose them because they make your numbers look better, which most people do. But if you could choose one that makes your number look better and decreases your mortality, isn't that better than just choosing another one that just makes your number look better? That's the first thing. Well, the second thing is this whole idea of doing stuff when you don't know why you're doing it. And going back way to the very beginning of my career, over a decade ago, I believe in giving things because I know what I'm treating. There's a case I had. One guy was, 50-year-old guy, was pretty ill, they thought. Definitely had a lot of, bandemia in his white count. That's pretty bad, 40-50%, which is pretty high. Had fevers. What was going on? I didn't know. His family was concerned. I said, look, I'm going to be around. If something is wrong, let me know. Meningitis popped up in my head, but he didn't have the classic signs. He was sleepy, but he's been up all night in the emergency room. I'm not sure how awake you're supposed to be. He's tired. Anybody would be. But I couldn't just give him antibiotics because, again, I don't know what I'm treating. They're different for different things. So I came back later because the family was concerned and our city is fine. Like, yeah, I think he's a little bit worse. Again, not the classic meningeal signs, but good enough. We'll start coverage for meningitis. And it did, and he got better. I couldn't do a lumbar puncture at a time because the ED doc had ordered, a shot of Lovenox because he said it was DVT, though he didn't get an ultrasound because it wasn't done in the middle of the night. So you can't do a lumbar puncture because it's just not safe. Anyways, he came back 1,000 white cells, so it is. Remember another case though, I was talking to a neurologist. There's a guy who's worsening. Not classic Guillain-Barré, but could he have some viral condition? Would pulse steroids help him out? He's a young guy, you don't want him to get intubated. But he said, I don't have a diagnosis, I can't treat him. And he didn't. I think the guy got worse. So after a decade of practice, where do I come in? I usually let the specialists do stuff without great evidence. But for myself, where do I draw the line? Between I'm just trying something versus it's worth a shot. I still don't start blood thinners willy-nilly. Another colleague did. The nephrologist I saw the other day with a patient both agreed you can't just start it just you have a high suspicion. It doesn't work that way. You have to actually prove something. Where do you go from this? I feel bad. I was talking to a guy at length every day for letting him get worse when I could have given him steroids and that would have prevented that. I don't know. I don't have an answer. Just something to think about.